First of all, can I thank the British Society for the History of Medicine for the invitation to deliver one of the keynote lectures at their National Congress in Edinburgh in September. And I should deliver my apologies also to all the participants for my failure to attend the meeting, and further thanks to the British Society for the History of Medicine for this opportunity to record the lecture for their website. Now, I wish to start my exploration of the distinctiveness or otherwise of Scottish medical practice in a place that is perhaps counterintuitive, namely the novels of Anthony Trollope. Trollope was an astute observer of the medicine of his day, and one passage in particular is of some relevance to our present concerns. In the novel Phineas Finn, published in 1868, Lady Laura has married the Glasgow magnate Robert Kennedy for his money. The marriage is unhappy, and Lady Laura often adopts a ploy familiar to us from popular domestic dramas. "Not now, dear, I've got a headache." Lady Laura's headaches tend to occur when she wishes to be excused from attending church with her dour and staunchly Presbyterian husband. However, I think the reader is allowed to infer that this stratagem may also be employed on other occasions within their marital relationship. The problem with the ruse, however, is that whenever she says she's unwell, her husband immediately summons a doctor. Kennedy is fabulously wealthy and could engage any doctor he wishes. Nevertheless, when residing at his Highland estate, he prefers to send a calendar for the local doctor, Dr. McNuffrey. Lady Laura complains. "And now I shall have that horrid man from the little town pawing me and bidding me take Scotch physic, which seems to increase in quantity and nastiness as doses in England decrease." It would seem that Dr. McNuffrey subjects Lady Laura to a more thorough physical examination than she's been accustomed to from her fashionable London physicians. It was, of course, not until the mid-19th century that physical examination became fully established within routine medical practice, and its introduction was not without controversy and opposition, particularly in respect of its application to women's bodies. Trollope is here, as he often does, taking note of a contemporary issue and deploying it for his own fictional purposes. The degree to which Scottish medical practice was distinctive in the mid-Victorian period is a moot point. But on the basis of my own investigations, I would certainly suggest that a doctor graduating from Edinburgh or Glasgow in, say, 1830 or even 1840 would have received more instruction in physical diagnosis than his Oxford or Cambridge counterpart. It is some respects of the background to this difference that I will explore in this lecture. I regret to say that it will be outside the scope of my expertise to consider the relative nastinesses of Scottish as against English physic. Now, it's conventionally assumed among historians of medicine that the typical 18th century physician did not examine the bodies of his patients directly. The accepted view is that most physicians relied upon four basic techniques in diagnosis. First, he noted the patient's general behavior and demeanor, visually inspecting those parts of the body not normally covered by clothes or bedclothes. Secondly, he took the pulse, usually at the wrist, a procedure that also allowed him to ascertain whether the skin was hot, dry or clammy, and so on. Third, he inspected urine and feces, and where available, blood, vomit, pus, and sputum. Blood, of course, was often available. Fourthly, and most importantly, he listened carefully to the patient's account of her ailment, supplemented by systematic questioning. As Bill Bynum has put it, the patient's own description of his illness was the pivotal point in the diagnostic process. In other words, in the 18th century, a consultation with a physician was, generally speaking, structured around the same social constraints that normally govern physical interaction between non-intimates. Doctors were not yet the licensed examiners of the bodies of strangers that they were to become in the 19th century. A famous illustration of Bynum's contention is provided by the final illness of the philosopher David Hume. Hume died of liver cancer, which was not diagnosed by any of the several London physicians he consulted in the course of a long illness. None of them ever palpated his abdomen. It was only when he was examined by the Scottish surgeon John Hunter that a diagnosis was arrived at. Nor was such reluctance to undertake a thorough scrutiny of the bodies of patients confined to fashionable London physicians. John Rutherford, Professor of the Practice of Physic at the University of Edinburgh, impressed upon his students the value of noting the patient's facial appearance. For instance, in the course of a clinical lecture upon the case of a young woman newly admitted to the Edinburgh Royal Infirmary, he remarked, "If it had been daylight, I would have examined her gums and the internal canthus of her eyes, for by looking into the internal canthus and the gums and finding them in a flooded state, then the blood is in a good state." Rutherford's careful inspection of the woman's face was not, however, extended to other parts of her body. He concluded that the disease seems to be owing to the mismanagement she underwent in childbed. She says she was lacerated, and probably it was her vagina. But he made no attempt to confirm his supposition with an examination of her genitalia, nor, it seems, did any other member of the hospital staff. However, important exceptions to this general picture can certainly be found. I have shown that the eminent physicians Gerhard van Swieten in the Netherlands and Giovanni Morgagni in Italy practiced physical examination, at least to some extent. Morgagni, moreover, performed many post-mortem examinations and made efforts to correlate the lesions that he found in dead bodies with the physical signs he had observed in the same patients while they were still alive. He had, in other words, a structural conception of disease and worked with something like what was later to be called the anatomical clinical method. That is, the systematic correlation between pathological and clinical observations. In a classic paper, Außer Temkin identified the anatomical clinical method as a newly dominant mode of medical research in the first half of the 19th century. And he ascribed this development to a rise in the status of surgeons and surgery, which in turn led to the assimilation of surgical modes of thought into the practice of internal medicine. In other words, physicians began to think and behave more like surgeons. They abandoned humoral theories, they conceptualized disease in localized structural terms, and they began to cultivate skills in examining the bodies of their patients. The key invention being, of course, that of the stethoscope in 1816, as I have explored in the Scottish context in an earlier paper. In attempting to explain why, unlike their contemporaries, Morgagni and van Swieten, were willing to cultivate an interest in physical examination, I have advanced what might be termed a corollary to the Temkin thesis, namely that, before the 19th century, wherever physic and surgery were socially and institutionally close to one another, there it was more likely that physicians would not seek to distinguish their practice from that of surgeons, and therefore would be more willing to handle the bodies of their patients directly. In other words, both the Temkin thesis and my corollary of it are predicated upon considerations of the social distance between physicians and surgeons. If physicians are an exclusive, self-perpetuating elite, as was the case in 1870 London, for instance, then physicians will seek to differentiate themselves firmly from surgeons and will cultivate a mode of practice distinctly different from that of their surgical counterparts. They will emphasize the superiority of the work of the mind and minimize the significance of manual skills. On the other hand, when physicians and surgeons are close together in social status, then it's less likely that such professional differentiation will occur. Physicians will be less anxious about losing caste by lowering themselves to handle the bodies of their patients, and will thus be more inclined to appreciate the value of physical examination. I pointed out that there was less professional and social stratification between physic and surgery in Morgagni's Italy and van Swieten's Netherlands than there was in contemporary London or Paris, for instance. Now, several scholars have described how surgeons and surgery were increasing in salience and professional importance as the 18th century went on. This process is very obvious in 18th century Edinburgh. It is well documented that surgeons played quite a prominent role in the public business of the city. The incorporation of surgeons was a prominent and influential institution within Edinburgh's guild structure. Its deacon often sat on the town council. And crucially, when the Royal Infirmary was founded in 1729, surgeons were able, owing to their political strength, to secure access to its wards on more or less equal terms with the physicians. And of course, medical teaching in Edinburgh University was effectively founded by two surgeons, John Monro and his son Alexander Monro, so-called Primus. Monro Primus was a genuinely remarkable man. Unfortunately, it is also remarkable how little close historical attention he has received. There is no definitive biography. It doesn't help, of course, that the archive of his papers is in New Zealand. Appointed as Professor of Anatomy to the Incorporation of Surgeons in 1721, at the age of 23, Monro had a formative influence on the development of the Edinburgh Medical School and the Royal Infirmary. He went on to make many important contributions to medical knowledge. He was also one of the founders of the Society for the Improvement of Medical Knowledge, which later became the Royal Society of Edinburgh, and he was the editor of its journal, The Medical Essays and Observations, which appeared between 1732 and the 1750s. The journal is, I think, one of Monro's great achievements, and an underappreciated one. I don't think that it is an exaggeration to say that under his direction, its several volumes were influential in the development of what might term a culture of research publication among British medical practitioners. I would argue that Monro's editorship gave the journal a distinctive character, reflecting his own combination of surgical, anatomical, and medical concerns. Monro himself published much of his important work there, and many of the other contributors were also surgeons. Most of the contributors were Scottish or had some connection with the University of Edinburgh, but the journal was very influential beyond Scotland, being republished several times and translated into French and German. Now, it's sometimes implied in accounts of the early years of the Edinburgh Medical School that from the time that his chair was transferred from the Incorporation of Surgeons to the University in 1725, Monro was increasingly an academic anatomist and a lecturer on surgery rather than an actual operator. If this is true, it is only partially so. His publications in the medical essays show him to have been active in the practice of surgery and operative obstetrics throughout the 1730s and 1740s. There is certainly no trace in Monro's writing, or indeed in any of the content of the medical essays, of surgery being regarded as inferior to physic, socially, institutionally, or academically, all in terms of its significance for therapy. And from a present perspective, it is interesting to note how Monro's impact on Edinburgh medicine was characterised by one of his most famous students, Andrew Duncan Sr., also to become, of course, a distinguished professor in the Edinburgh Medical School. Monro took every measure for inquiring into the causes of diseases by dissection. He personally attended the opening of every body, and he not only dictated to the students an accurate report of the dissection, but with nice discrimination contrasted the diseased and sound parts of every organ. Thus, in his own person, he afforded to the students a conspicuous example of the advantages of early anatomical pursuits as the happiest foundation for a medical superstructure. His being at once engaged in two departments, the anatomical theatre and the clinical chair, furnished him with opportunities both in the dead and living body, and placed him in the most favourable situation for the improvement of medicine. And from these opportunities he derived every possible advantage which they could afford. A description, in other words, in mid-18th century Edinburgh, of something approaching the anatomical clinical method, some decades before the innovations of the Paris School, and indeed before the major research achievements of John Hunter in London. And we might also note that Monro was elected an honorary member of the College of Physicians in 1756 at the age of 59, and that in his eulogy Duncan described him as a physician. It is hardly possible to conceive of a physician more attentive to practice, or a preceptor more anxious to communicate instructions. His humanity in the form of these characters led him to bestow the most anxious cares on his patients while they were alive, and his zeal in the latter induced him to make them the subject of useful lessons when they happened to die. Duncan is again ascribing to Monro something like the anatomical clinical method. Now, what I'm arguing here is that there existed in 18th century Scotland relatively less social and professional distance between the two branches of medicine than might be found in many other places in Europe, and certainly in the English capital, and that this relative closeness impacted upon how medicine was conceptualized and practiced. With this in mind, I'll go on to examine the work of a man who was not a surgeon but a physician, and had practiced not in Edinburgh but in St Andrews, namely Thomas Simpson, who was the first Chandos Professor of Medicine at the University of St Andrews. Simpson has received little historical attention, even less than Monro, and there's little extant archival material. However, Simpson was a prolific author, and it's possible to reconstruct something of the character of his practice of medicine from his publications. He was, for instance, a regular contributor to the Medical Essays and Observations. He also published 2 books in English and 1 in Latin. The last, unfortunately, is inaccessible to me, but from his writings in English, an intriguing picture emerges, which certainly challenges some historical assumptions about the character of the practice of physic in 18th century Scotland. Born in Ayrshire in 1696, Simpson was awarded an MD from the University of Glasgow in 1720, having presented his thesis De Fluxo Menstruo, and was accordingly admitted into the city's faculty of physicians and surgeons. He was appointed to the Chandos chair in 1722, Monro being one of his referees. At this time, the University of St Andrews did not have an undergraduate medical course, so there was little opportunity for him to function as a technical medical educator. Nevertheless, Simpson seems to have been active in his academic role. He served as the examiner of the external candidates for the St Andrews MD degree, and delivered several series of lectures which were clearly intended to be of interest to a broad educated audience as well as those professionally involved in medicine. Simpson's major publication, an inquiry into how far the vital and animal actions of the most perfect animals can be accounted for independent of the brain, published in 1752, was based upon these lectures. Now, it's a major book, more than 260 pages long, and is best described as an exercise in what Mike Barfoot has helpfully termed scientific metaphysics. Simpson's purpose is to explore the relationship between the soul and the body by means of physiological, clinical, and comparative observations. I'm not going to go into any of the arguments of this book today, but my point is that Simpson is here engaged in a form of medical high theorizing which is quite typical of his time. In this respect, he's doing what a theoretically minded academic physician might be expected to do. And in his prescribing practice, he adopts a polypharmacy, which is again typical of his time and his rank, as far as I've been able to discern. However, in some other respects, as we shall see, Simpson challenges our understanding of what a physician, far less a professor of physics, might get up to in the early 18th century. Simpson was a long-term friend and close associate of Alexander Monro, but it was a friendship not without a certain creative academic tension. In an article published in the Medical Essays in 1733, Monro credited Simpson with communicating to him the general doctrine of jaundice depending on concretions of the bile duct. Monro proposed that jaundice was caused by obstructions of either the cystic duct or the common bile duct, usually by calculi. Simpson promptly responded to Monro's suggestions. Their 2 articles appeared consecutively in the Medical Essays, so Monro must have shown Simpson a copy of his essay before publication. Despite having been generously accorded the credit for the idea of ductal obstruction, Simpson advanced some caveats. He argued that a disorder of the blood, rather than of the liver, was responsible both for the jaundice of the newborn and for that which accompanied the malignant fevers of the West Indies. And drawing on the recent anatomical literature, he suggested it was the common bile duct, rather than the cystic duct, that was the most common locus of obstruction. Thus, he concluded, how anatomy duly attended to not only leads to the best theory of diseases, but corrects what had taken place from a less accurate anatomical survey. Now, I'm not sure that this bad comment is directed specifically against Monroe or not, and it was certainly a brave man who made such a comment directly against Monroe. But what is certainly evident is that Simpson and Monroe are participating together in forming and sustaining the particular research culture that characterizes the medical essays and observations. During his time at St Andrews, Simpson evidently acquired considerable experience of post-mortem investigation. In an essay published in Medical Essays in 1752, he writes, "In a great many I have opened down of a volvulus, I have often found a strong inflammation, reaching at once the whole coats or thickness of the intestines. In one I have found more than a foot of the ileum, of as deep a red as vermilion, forced within the cecum and colon. I found the cecum and most of the colon in a second body stuffed together, and lying likewise upon the left side. In a third I found 4 different parts of the ileum differently engaged, though all greatly inflamed." A total of 4 post-mortems are mentioned in this one article. Although none of these dissections relate directly to cases that he diagnosed in life, Simpson draws the definitive conclusion regarding the appropriate therapy from his pathological investigation. "So the inflammation would appear to me to be the original disease, and to require large blooding rather than the strong purges of quicksilver recommended by Roche. Bleeding, of course, being the standard 18th century treatment for inflammation." On another occasion, Simpson explains, "There is nothing which modern physicians have trusted more in their explaining diseases than the appearance found in diseased bodies opened after death. And what could give greater satisfaction than with our eyes to view the seat of the disease?" Again, something like an early expression of the anatomical clinical method. On occasion, Simpson is happy to admit that post-mortem investigation has caused him to revise his previous understanding of a case. For instance, in 1746 he wrote, "I opened a brewer who for many years past had very little respite from severe colic pains. I found the hard tumour, which I easily felt externally, and always had judged to be in the mesentery, to be in the cecum, which I slit quite across, and yet a difficulty to extract from it 2 large tumours." In other words, Simpson had palpated his patient's abdomen while the man was alive, but had been mistaken in his location of a tumour, a mistake the autopsy subsequently corrected. It's worth noting that, like Monroe, Simpson is willing publicly to admit such mistakes, which makes both men quite unusual in the context of contemporary medical discourse. But it should also be noted that the frank admission of mistakes is specifically encouraged in Monroe's preface to the first volume of the Medical Essays. It is an integral aspect of the research ethos of the journal. Another example from Simpson. A countryman had an uneasiness in walking from a pain in his left knee. When the pain was greatest, he found something of a hard body immediately under the rotula. I easily catched it betwixt my thumb and finger, where it felt so distinctly that I could not suppose but it had its seat in the tunica adiposa, immediately under the skin, which made me immediately pull out a bisturi to open into it. It's, however, only some days later that the patient consents to the operation, by which time the object in his knee appeared so loose and superficial that I had no manner of doubt of success, and with a scalpel immediately began to make an incision upon the body. But to my great surprise, I found a membranous strong bag between me and the tumour, which made me sensible for the first time where this floating body was lodged. Nevertheless, Simpson continued with the operation, eventually removing the hard body with 4 ounces of fluid. Note that here we have a professor of physics not only actively examining his patient's body, not only performing a surgical operation, but, as you saw from the previous slide, apparently carrying a surgical knife with him as he goes about his daily business. Not behaviour one is led to expect from a professor of physics. Nor was opening a knee by any means the most heroic surgery Simpson performed. A farmer's wife in this country found a small tumour forming about the jugular vein, which increased to the bulk of her 2 fists. It broke upwards of a year ago, ulcerated, and ran a great deal of stinking sinews. When I saw this ulcerated tumour, it sunk deep into the fossa on the right side of the aspera arteria, so that, knowing its base must be very near the carotid artery and the internal jugular vein, I was unwilling to undertake the extirpation of it, but was afterwards prevailed on to perform the operation, as being the only chance the woman had of life. In dissecting out this tumour, I laid the carotid artery bare for about 2 inches, and plainly saw its pulsation. The woman was still alive when Simpson wrote up his account of the case. Formidable surgery for the 1750s, you will agree. I'm led to understand that exposing the carotid artery, as well as its inherent dangers, requires the careful displacement of a number of superficial structures, and of course all on a conscious patient. It's also noteworthy that Simpson practiced operative obstetrics, in particular craniotomy. A woman 40 years of age, observably narrow between the ossa pubis and the os sacrum, had been 4 days in severe labour of her first child when I was called to assist her. The child appearing to be dead for some time, I opened his head and extracted it. He suspected the woman's bladder had been damaged, and he writes he was confirmed in his opinion by introducing a catheter into the bladder, for whenever it touched certain parts of the sides of the bladder, blood came with the urine. In another case, I was called to a woman who continued very hard in labour, though delivered of her child, and whose belly, immediately above the os pubis, was bulky and hard. I could not determine what the case was till, examining with my hand, by which I got easy access into the uterus, which was hard and inflamed all round its cavity. Again, Simpson evidently did not feel that his dignity as a physician, indeed as a professor of physics, was diminished by undertaking this sort of investigation. Indeed, he's not above pulling the odd tooth, an activity often regarded even by some surgeons as quite menial. It's also noteworthy that Simpson's physical examination is not confined to surgical or obstetric cases, as the following indicates. A lady who came under my management after being bled and frequently vomited and using several anti-asthmatics had a thickness of her face, which made me to examine her ankles, and they, bearing the impression of my finger a little, showed me the first degrees of the anasarca. And he goes on, and thus by anatomical consideration I was directed to the cure of my patient, as I am in many other cases. And his examination of the female body in medical cases is not limited to the extremities. Upon examining a young hydropic girl, he writes, I have often met with in persons whose belly was much distended, particularly in ascites, covering 1/2 of the sternum, its cartilage, and some inches below. This raised part looks more transparent than the parts about, and pressing its middle with your fingers, you find a great vacancy between the skin and the sternum or cartilage. It is elastic and stretched like a drumhead. Remarkably, Simpson was also interested in medical devices. He devised an ingenious spring-loaded vaginal pessary, which a woman could readily insert by herself. All the pessaries which I have seen described by authors or used by practicers in medicine seem to me defective and inconvenient. For the ants of the design buy their bulk only, and must be thrust violently into the vagina, which not only occasions a great deal of uneasiness and pain to the patient, but a skillful hand is always required to manage them, which many women are unwilling to allow. Simpson thus acknowledges that gendered sensitivities involved in medical work on women's bodies, but seems not at all concerned that being directly involved in such work is incompatible with his professional, or indeed professorial, decorum. Thus, Simpson is a highly qualified, high-status physician with the academic interests of a medical professor, who seems nevertheless willing to turn his hand to whatever medical intervention was indicated for each particular patient. In other words, in certain circumstances at least, Simpson's repertoire is more like that what we would associate with an 18th century surgeon apothecary, a general practitioner in the older sense of the term, rather than a professor of physics. How then do we explain the range of services that Professor Simpson offers? It must be acknowledged that we don't know much about how medicine was practiced in small towns in 18th century Scotland. We do know that several small towns, Kelso for instance, had surgeons or surgeons' apothecaries. But as I say, we know little about their practice. I regret that I was not able to attend Ursula Mulcahy's paper at the BSHM about 18th century Scottish surgeons. I look forward to learning more about her work in the near future. However, as she points out in her abstract, and as Irvin Loudon has argued in respect of the English surgeon apothecaries, much of the work of a small-town surgeon involved treating medical conditions, dispensing drugs, bleeding, perhaps dressing wounds and ulcers, rather than operative surgery as we would understand it. I think it's unlikely that these men were very respectful of precise professional boundaries. For financial as well as clinical reasons, they would have provided their patients with a broad range of services, consulting a physician only occasionally in problematic cases, and when the patient could afford the extra fee. St Andrews, as I say, was also a small town, a location in which professional distinctions, dignities and niceties, which sustained to some extent the division of the profession in Edinburgh, evidently applied less strictly, did not apply even to the university's professor of medicine. So one might think that just as a small-town surgeon apothecary might in effect practice physic, so a small-town physician might undertake some surgery. However, it should be noted that in the context of an 18th century small-town practice, Simpson does a remarkable number of surgical operations. And also it would be a very unusual small-town surgeon apothecary who undertook as many post-mortem investigations as Simpson seems to have done. In other words, while the fact that he practiced in a small town may be part of the explanation for the diversity of his activities, it is not the whole explanation. What is very noteworthy, indeed remarkable, about Simpson is the fact that he publishes detailed accounts of what he does. Here we have a professor of physics willing to publicize his work not just in high theory, anatomy, orthodox physicking, but also in surgery, obstetrics, gynecology, and even dentistry. I think we can see here the influence of his association with Munro Primus. It is the character of Munro's editorship that creates in the medical essays a space for such publication. A journal which itself recognizes no boundaries between physics and surgery, but treats all contributions to medical knowledge as of equal status and equal potential value. And that, as I say, attaches no stigma to the manual activities of surgery or physical examination. It's worth noting in this context that Munro specifically encourages the Scottish surgeons and surgeon apothecaries to publish in the medical essays. I would like now to draw some parallels with 19th century Edinburgh. In a paper I published in 2013, I identified James Young Simpson, the eminent Edinburgh obstetrician, in no relation to Thomas, as far as I know, as a very important pioneer of physical examination in the first half of the 19th century. Again, I would argue that the roots of his diagnostic practice lay in what I once, on another occasion, rather pretentiously termed the triangle of fructification between surgery, pathology and physical examination. As an obstetrician and gynecologist, Simpson's practice necessarily incorporated elements of both internal medicine and surgery, and he was thus well placed to argue that the former might be improved by techniques and attitudes derived from the latter. Simpson considered that it was in the field of diagnostics that medicine had made its most significant advances in the first decades of the 19th century, as exemplified by the enhancements in the understanding of diseases of the heart and lungs that had been achieved by means of auscultation and percussion. Again, as I said earlier, the key innovation is the stethoscope. The greater accuracy of thoracic diagnosis stood as proof of the superiority of physical means of diagnosis over what Simpson termed rational or functional symptomatology. Surgical diagnosis is as a whole more accurate than medical diagnosis. But why is the surgeon more accurate in the discrimination of the affections which he treats rather than the physician? Merely because he can and does found his diagnostic deductions far more upon physical symptoms. The closer medical diagnosis approximated to surgical diagnosis, the more accurate and useful it would be. Physicians should learn to handle their patients like surgeons. It is noteworthy also that James Simpson had a background in anatomy and pathology. His first academic post was as assistant to John Thomson, the professor of pathology. As a lecturer in pathology, Simpson assimilated and articulated a structural conception of disease. The interpretations that Simpson put on the information that he gathered from the physical examination of his patients was firmly based upon his knowledge of pathological anatomy. Loyal to the example of the pathological anatomist of the past school, whose work he admired and from which he often quoted, Simpson regularly followed those of his cases that terminated fatally into the autopsy room. Thus, by comparing post-mortem appearances with clinical signs and symptoms, he was able to improve his understanding of the tumours, abscesses and adhesions that he'd sought to locate in the patient's pelvis and reproductive tract while she was alive. As a preeminent obstetrician, Simpson functioned as what we might call a bridge between the two branches of medicine. His relations with surgeons were not always cordial, but they were evidently conducted upon the assumption of equal professional status. Simpson stands as what one might call a personification and exemplification of the Temkin thesis about the impact of surgical attitudes and practices on the character of 18th century medicine. My point today is that in the case of both these Simpsons, James and Thomas, we can see how a particular set of circumstances, namely a relative lack of social distance between surgery and internal medicine, with a resulting respect for manual skills, helped produce distinctive forms of medical practice. And this is a set of circumstances whose influence we can discern not only in a small Scottish university town, but also in Scotland's major centre of medical education, the University of Edinburgh. We can see it there in the 18th century in the example of Alexander Monroe, and in the 19th in the example of James Young Simpson. And I believe, although I do not have time to develop the argument today, that we could also see a similar conjunction of factors in 19th century Glasgow. In essence, what I am talking about is the emergence of a distinctive research culture in Scotland, exemplified by the productions of Alexander Monroe and Thomas Simpson. A research culture which brings together physics and surgery, which encourages physical examination, and which certainly anticipates, in some key respects, the anatomical clinical concerns of John Hunter and the Paris School later in the 18th century, and which extends its influence well into the 19th century, beyond James Young Simpson, indeed, I would assert. Of course, not every academic Scottish doctor can be associated with this mode of research. I have already alluded to John Rutherford having only a partial interest in physical examination. William Cullen was quite indifferent to pathological anatomy, and there is little or no evidence of physical examinations in his writings. But it's worth noting that both Rutherford and Cullen are more famous as teachers, systematizers, as educational reformers than as researchers. To be clear, I'm not saying there were no divisions of status and class within Scottish medicine in the 18th and early 19th centuries. Of course there were. But what I am saying is that there was nevertheless an identifiably distinct Scottish research ethos, which was socially and professionally inclusive and was sustained by a shared understanding of the essential unity of medicine and by a set of social circumstances that gave something like equal value to all the branches of medicine, to physic, surgery, obstetrics, and indeed to anatomy, pathology and pharmacology, all acknowledged together as having potential for the improvement of medical knowledge.